A lot of what we know about the toxicity of chemotherapy comes from what we know from the TROPIC study, which was the study that led to the approval of cabazitaxel, and that carried forward onto CARD. There was not a new signal. There were not new toxicities that were shown to develop in the CARD study that weren't really present in the TROPIC study. In that setting, I think the main toxicity that one needs to be aware of is hematologic toxicity. And in fact, that's really it. I don't think that in my experience, and the data seem to support that neuropathy, for example, is not so much worse. There was a signal about some adverse events of diarrhea in the TROPIC study. I think that has not really carried forward quite so much, but it does happen. Patients do develop some mild diarrhea that's very, very manageable in the case of cabazitaxel. But for the most part, one can expect neutropenia in patients, and if not adequately managed or prevented, neutropenic fever can occur in anywhere from 5 to 15% of patients. It's really clinicians' choice about whether they use upfront growth factor support. And keep in mind that the studies with comparing the two doses of cabazitaxel, 20 milligrams per meter squared and 25 milligrams per meter squared, did suggest that there was greater hematologic toxicity in the 25 milligram per meter squared dose. So if you're using that dose, I would recommend serious consideration of growth factor support. If you're using the lower dose, you may still get it. You also have the option of choosing one of those two doses in the clinic at this time. But there was data to suggest that there really wasn't so much of a difference. So for many, 20 milligrams per meter squared is the dose, even though 25 milligrams per meter squared has been used in some other studies. With regards to other hematologic toxicities, thrombocytopenia can occur, although grade 3, 4 or clinically significant thrombocytopenia is actually quite rare.